Hello friends, this is a case of laparoscopic myomectomy. This patient has few months ago ectopic pregnancy surgery was performed for the right tubal pregnancy, and at that time several myoma was found, and after few months we are performing the laparoscopic myomectomy. So here we are putting various needle in supraumbilical area, and then suction irrigation hanging drop test is performed, and now we will connect the insufflator tubing, and now insufflation is started. So she has multiple myomas. There are several subserous and few intramural, which is intending the cavity as well. So here preset pressure is kept to 15 and flow rate is 1 liter per minute, and we are insufflating the abdomen. So slowly pneumoperitoneum is building up, and approximately 3.5 liter CO2 has been introduced, and we can see homogeneous distension has developed, and we will take now various needle, enlarge the incision, and we will put the first port, that is the optical port. So incision is enlarged now to 11 mm, and this is the first optical port has been introduced. Total only 3 port we will do. First optical is 10 mm and then 2 5 mm. We will use the same scar which was on the previous part because inside there is no adhesion. So just to minimize the number of scar, we will use the same scar where the first port was introduced during the ectopic rupture, and this now patient head is going down, and we will put the third port. So this is just 1 centimeter above the anterior superior iliac spine, and these are the two ipsilateral operating port is introduced. Right side we are using harmonic, and left side a grasper is introduced. Now we can see a lot of adhesions are there. Sigmoid is also adhered, and this is a large subserous fibroid on the right side. We can see a lot of adhesions are there. So first these all adhesion will be removed. So these are not the direct adhesion of the serosa. So these are flimsy adhesions. So that can be easily separated with the harmonic. We can see on the left side also, with the uterus bowel is adhered, that also has to be separated. This is a band with the previous surgery. Some free fluid is there in the pelvis, and little oozing is happening at the time at the place where adhesion was present. We can see there are few fibroid on the anterior wall as well, and this is the left tube which looks normal. Fimbria is also fine, and below is the left ovary. Slowly with the suction, the blunt adhesiolysis is being performed to separate this bowel loop from the uterus and fibroid. So these are some adhesion. There is one more fibroid subserous which you can see on the top of the uterus. Some adhesion with the bladder. That also is separated. This is again adhesion with the sigmoid. So those adhesions are now free. Posteriorly, more fibroid is seen. So with the tip of the ligation, we are doing blunt dissection to free this fibroid from the lateral pelvic wall. Left side is the iliac vessel, and below is the right ovary. Right, left side you can see below is the left ovary. So first now we will remove this large subserous fibroid which is on the left side. Then other fibroid will be removed. So we will use a myoma screw here to give the cranial traction to that fibroid. Bowel loop is getting separated, and tube and ovary of the left side is also separated from the fibroid. So sigmoid is now fully free, and most of the adhesions of these fibroids are separated. Now we are separating this with the harmonic, and from the base of this fibroid we will cut the serosal attachment and remove first these large fibroids. So here you are using the harmonic like a saw, and which is cutting the fibroid of this area. Myoma screw is used to give anterior traction. So this large fibroid has few multiple fibroids also attached. So all together we will divide it. So left hand is giving anterosuperior traction, and with the right hand with the harmonic we are separating this fibroid. So this large fibroid with few more is removed, and now these are the other fibroid that also one by one we will remove. Little suction is done. A lot of suction has no advantage, because first we will remove those fibroid, then only clear picture of the uterus will be visible. So with the suction you can palpate the boundary of this fibroid, and we have to keep in mind that left tube of this patient was already removed before due to the ectopic pregnancy. So we will try to save the right tube so that she can conceive. The patient is nulliparous, so it is important that right tube should be not damaged. So this fibroid is also subserous. Myoma screw is applied. Serosal plane is enlarged, and then this will be serosa will be retracted to remove this fibroid as well. Now cranial traction is given to facilitate the enucleation of this fibroid. Here little oozing is there, so better to use ligashore in this area. There is no much space in this patient to use vasopressin because all around fibroids was surrounding. So now this fibroid is also removed, and we will look for the another fibroid here. Myoma screw is again applied on this fibroid. And this one is also now separated. We are keeping all the fibroid stored in the right iliac fossa so that it should not go to the bowel loop, and then we will go for the other fibroids. This is posterior wall. We are trying to palpate with the tip of the harmonic and try to find out the consistency of the fibroid. So here it was felt that one more deep intramural fibroid is present. Little suction is performed. We can see that there is adhesion in the cul-de-sac. Those adhesions are with the rectum and the surrounding organ. This is the area of ureter, of the left ureter, so we have to be careful. These are some few small fibroid that also we will remove. Because if you will leave it after few months, it will also increase in the big size. Again, this is also one. Here is also one big intramural fibroid, as you can see. But let us remove this smaller one. After that, we will go for that one. So total 7 or 9 fibroid we have removed from this patient. And now again this is one more fibroid which is deep intramural. That also will be separated. So again myoma screw is applied. And this is also a large fibroid. Luckily this patient has not been previously treated by GnRH. So the fibroid has the good plane. And this deep fibroid is also removed. After that, now it looks soft because these areas are muscle of the uterus, so they don't have fibroid now. This is ovary. So now we will start suturing. Here we are using barb suture, that is V-lock, and start suturing with the healthy area with the deep muscular bite. Now this is upper edge of the serosa with the muscle. We have made a big loop with the V-lock, just like Dundee jamming knot, and we'll pull the needle through this loop so that it get locked. As we know that V-lock suture is single direction, it only go ahead, it doesn't come back. So this is the starter knot and it is locked at this level. Because we are doing by only 3 ports, so there is no assistant. So with the left hand you have to hold it, with the right hand you have to take a bite. Again this is a deep seromuscular bite. And it is pulled tightly to lock this area, and now further bite will continue. So we will suture it completely with the several layer to make the uterus completely strong, so that there will be no any problem during pregnancy. Muscle was not cut in any of the incision here because fibroid was removed by separating the muscle. So still the muscle is strong and it is in the position. Otherwise we would have taken muscle layer separately and serosa separately. But here incision on the muscle was not taken, as you have seen throughout the procedure. Muscle was only splitted to take the fibroids. Now we can see uterus started looking normal in the shape, and this vertical incision we will take out. There we can see one more fibroid is looking like. However, it is subserous, but that also we will remove because in due course of time it will also become bigger. So this is very small, just you can directly pull it out. Barb suture has little memory, so sometime holding the needle, it jump from the needle. So we have to be little tricky to just hold the needle. Now we are returning back from this returning longitudinal suture line, and then vertically we will close this incision. So we can see it is vertical closure now, and edges are approximating. So during suturing we have to take deep bite, and care should be taken that needle should not bend, because sometimes needle bends in the deep bite. After that you have a problem. So we can see bleeding is already stopped. Those blood what you are seeing is those dark blood, those are collected blood. Here we will take one by one bite because it was thick muscle. Left side of tube in this patient is already removed before, so we don't have to worry about that. And now we are taking second layer by returning back to this vertical incision. This is a unedited video. We have not cut the part of the video, just we have cut little bit at the time of cleaning the telescope. So this is a full length video. And this is now again second layer. Suturing is complete. So it's look good now. Below is the tube and you can see the ovary. There is no bleeding as such. These are the collected blood. Uterus shape is regained. Right tube is good. And uterus is now looking good in the shape. There is no fibroid as such now. So 7 fibroid was removed. Now we will terminate the suture. In barb suture directly you can terminate. You don't have to tie a termination knot. And needle is taken out. And after that this we will cover this entire uterus with the large size interseed. This is reoxygenated cellulose just to prevent adhesion. So entire anterior cul-de-sac in this area over the anterior surface of the uterus and entire incision line we are covering with the interseed as well as posterior part of the incision. So interseed will not allow adhesion to develop. And you can just press it over. So once it will come in the contact with the fluid, it will stick with the uterus. Fimbria of the right tube you are saying just in front of the interseed. So fimbria should not be covered by the interseed. Otherwise the right tube will stick with the incision line of the myomectomy. So fimbria is outside the interseed, and we can see it is stitching. Sometime you can put few drop of saline also. And now we will do morselation. Morselation is a time taking job, as you know that it need to be done carefully. And all these 7 fibroid we have morselated. Here we are using a storage morselation. Patient is young, infertile, so there is no issue of any malignancy. So these are the smaller fibroid, and the larger one need to be nicely morselated by holding with the tenaculum. So after properly morselating and taking all the fibroid out, this is the 12 port. So we will close it by the port closure. We will do the entire port closure. A small fragmented fibroid also we will carefully take it out with the stone holding forceps. So just watch the morselation. It will be taking little time, and after that port closure and surgery will be finished. So thank you very much for watching this video. Have a nice day. Just see the morselation and surgery will be finished. So have a nice day. Thank you.